Assalamu alaikum and good evening, everyone. On behalf of Saudi Patient Safety Center, I welcome you all to this webinar, Safer Cesarean Section Birth in Placenta Accreta Spectrum. My name is Dr. Adila Zulfikar. I am Registrar OB-GYN, currently working in Maternity Hospital, King Faisal Medical Complex, Taif, as Quality and Patient Safety Officer. You will be hearing a presentation from Dr. Mustafa Al-Waraki, our Head of Department and Senior Consultant Obstetrics and Gynecology in Maternity Hospital, King Faisal Medical Complex, Taif. He will be speaking to us about the topic of safer cesarean section birth in placenta accreta spectrum. Just a little introduction about Dr. Al-Waraki. He's the Head of Department of Obstetrics and Gynecology Department, Maternity Hospital, King Faisal Medical Complex, Taif. Previously, he was a senior consultant in the same complex for 5 years. Dr. Mustafa, he graduated in Faculty of Medicine in Egypt as one of the top 10 in 2001. He achieved his master's degree in obstetrics and gynecology in 2006 in relation to obstetrics ultrasound, then studied MD in obstetrics and gynecology in urogynecology subspecialty in January 2012. He worked at the faculty hospitals as a resident till he achieved the degree of assistant professor. Now, moving on along to our session, I will welcome Dr. Mustafa Al-Waraki to please deliver his presentation on this very timely subject. Welcome, Dr. Mustafa.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Adila, for your nice introduction. Thank you to everyone at Saudi Patient Safety Centers for sharing this invitation to share our opinion and the experience and to help reduce morbidity associated with placenta accreta spectrum under title of Safer Cesarean Section Birth in Placenta Accreta Spectrum. Placenta accreta spectrum is a morbid condition that is characterized by the failure of detachment of placenta at the time of delivery and may cause or result in life-threatening bleeding. Transfusion and delivery occurs about 50% of patients. Intensive care unit admission is frequent, and the operative injury to the lower urinary tract is about 5 up to 30% of cases. Plus, cesarean hysterectomy with consequent loss of fertility has long been considered the standard treatment or management option, plus or minus delivery before fetal viability, if life-saving may lose the baby also. Patients with that experience higher rate of repeat hospitalization, need for additional surgery, long-standing psychological and emotional problem, which have great poor impact on quality of life of the patient, even longer time postpartum. Unfortunately, the incidence of such a syndrome is increasing. By bold estimate of placenta accreta spectrum is now around 0.17% of pregnancies. In comparing for the past, for example, 1970s or 1980s, it was about 0.02% and 0.04% respectively. However, accurate population-based statistics are hard to come by because placenta accreta spectrum coding and definitions just last recently defined by international classification of the disease. The increasing rate of such syndrome is likely to change in risk factors, most likely by increasing rate of cesarean delivery and, by the way, increasing rate of development of placenta previa. Regarding the causes and their risk factor associated with such syndrome, the exact etiology or cause of such a problem is unclear. Historically, it was related to abnormal trophoblastic invasion. However, new model investigation create or incite an event of trophoblastic attachment to an abnormal uterine wall, not abnormal invasion, but abnormal uterine wall and subsequent placental growth with progressively adhesive uterine scar. The most significant risk factor for such syndrome is placenta previa, diagnosed in patients with past history of cesarean section. And it's very important to put in mind for any screening and even diagnosis. Other areas of uterine insults, such as after myomectomy or endometrial scarring for DNC, Asherman syndrome, prior endometrial ablation, multifetal gestation, or in treatment of infertility, is also associated by increased such rate of placenta accreta spectrum. Here is the usual classification of such problem, and as the right side, we can see historical classification, which is still used by most of even textbooks up to William 26th edition. as placenta adherent, accreta, increta, and percreta. We have two other classification, pathological classification and the clinical classification by FIGO, which consider mirror shape for each other, normal and normal. Normal, it means pathologically layer of decentralized endometrium separate placenta from myometrium, which reflected clinically by able to separate the placenta spontaneously or even manually. Grade 1 is thought to be adherent, the absent decidua between villi and endometrium, but still there is uniform formal myometrial thickness without any thinning. Reflected clinically by unable to manually develop a clear planned separation between decidua, between placenta and the myometrium, even or often indicating for or requiring curette. Grade 2, more and more development of the syndrome, pathologically في irregular placental myometrium interface with involvement of part of the myometrium, but still less than 75% of the total myometrium, and we have still intact serosa, reflected clinically by FIGO as abnormal macroscopic finding over placental bed, placental bulge, hypervascularity, dimple sign, and uterine balling in gentle cord traction. Ongoing for grade 3 for both more and more development of increta up to percreta. There is irregular placental myometrium interface and the invasion and the involvement of the myometrium up to 75%, but we have still antiserosa reflected clinically by tissue seen through the uterus without extension to any other organs, mean antiserosa. Appearance of trine window with base of placenta visible through very thin myometrium or even just a single layer of serosa. Group D subdivided pathologically 3D, a deeper invasion with disruption of serosa and the clinically involvement of adjacent organ, but superficially, I mean urinary bladder mostly. In the last and at the most serious or affected grade 3A pathologically, it means extrauterine extension invading clinically the full, maybe the full thickness of the urinary bladder. Here, accreta, more involvement of bottom increta and more up to percreta. This figure shows from up down the involvement of myometrium up to involving the full thickness plus or minus the serosa. Maybe involving other adjacent tissue and structure. I'm sorry to say that tools for diagnosis of placenta active spectrum in total are imperfect, and many patients are not diagnosed until the time of delivery. Consequently, and as a big recommendation, risk factor assessment and ultrasound, both together should be the foundation of placenta active spectrum screening and diagnosis. It's important to note that patient risk factor should not be dismissed on the basis of reassuring study. Regarding the role of MRI, it is of limited role in certain situations due to higher cost, limited availability, and it needs experience in interpretation of placental MRI. On discussing risk assessment, for me, it is the first and the primary screening modality or tool. Clinician and the ultrasound unit should screen for history of cesarean delivery plus or minus other uterine surgeries. Unlike imaging, this step does not require advanced experience, yet it is the most important step for screening because it influences imaging interpretation seriously. For example, the presence of placental lacunae or subplacental vascularity is significantly more concerning in patients with prior 3 to 4 or more cesarean section, and it could confirm the diagnosis. Comparing with identical ultrasound findings in patients with no uterine surgery before can consider as normal variation. Patients with risk factor for placenta spectrum should undergo systematic evaluation of the placenta at multiple times, starting so early in pregnancy, as we recommended before, started at 6 to 10 weeks of gestation to detect the confirmed diagnosis and manage what we call cesarean scar ectopic pregnancy, which can consider as precursor for development of placenta accreta spectrum later on. Start from the mid or early in the second trimester, patient with any number of prior cesarean delivery should have placenta location clear, defined in relation to the scarred area which located above the cervix. If the placenta is well and away from such area, the possibility of such syndrome is very low. Conversely, if the placenta overlies in such area, meticulous evaluation for ultrasonic sign of placenta acute spectrum is highly recommended to confirm the diagnosis and alert the team and start your management strategy or protocol. Role of ultrasound. Of course, in patient at risk, ultrasound is the primary screening and diagnostic modality. The most important sign is placenta previa. The risk factor for such a problem is considered able by increase the number of prior cesarean section. I mean, the increase the order of cesarean section plus previa, the increase the incidence of development of such placenta acute spectrum. For example, previous 1, 2, 3, 4, and 5, the plus placenta previa, the incidence of development of placenta acute spectrum is 3, 11, 40, 61, and 6, 7 respectively. It is important to note that absence of ultrasound finding for placenta acute spectrum does not exclude the diagnosis in patient with previa and the clinical risk factor. Based on recommendation of Society of Maternal Fetal Medicine, the most important sign alarming the clinician or ultrasonographer for the presence of placenta spectrum are loss of normal hypoechoic area zone between placenta and myometrium, myometrial thinning less than 1 millimeter, placental lacunae, subplacental hypervascularity, bridging vessels, placental bulging, bladder wall interruption, or exophatic masses or uterovesical hypervascularity. Again, no individual sign is highly predictive alone. So combination of findings, ultrasound and risk factor help to determine the overall suspicion. Here we can see the invasion of the start of placental to bring the interface of bladder, hypervascularity, start to be some sort of bulging as the interface with bladder, more and more has lacunae, and so on. Magnetic resonance image, MRI. The role of this modality is less well defined because it needs special experience in interpretation placental MRI, expensive. And by most organizations and studies, it may be equivalent to ultrasonography in diagnostic accuracy, especially if added Doppler study plus ultrasound study. The most common MRI feature associated with such syndrome are abnormal triangle bulging, dark intraplacental bands in T2, disruption of uteroplacental zone, disorganized placental vasculature, heterogeneous placental sign intensity. However, the most common used marker and with good sensitivity are placenta previa and the placental bulge, which can be easily diagnosed by accurate ultrasound. Here, placenta previa is diagnosed, which is the same between ultrasound. Invading here, start to very thin myometrium behind, start of bulge, and such can be seen clearly regarding. What I said before, you could consider as introduction or identification of the syndrome to be alert about what we are going to say. From this slide, I will be deep in the core of our project, how to do antenatal staging and the morbidity prediction. I mean, what is the future of placenta acute spectrum diagnosis? Detecting a placenta acute spectrum diagnosis is very, very important, essential first step for diagnosis. But of sure, it is not the whole story. Key questions that will be helpful to the surgical team, including how certain are we that this patient has placenta spectrum? Where the placenta located in uterus and pelvis? Where can surgical difficulty be anticipated? Answering this question helps to formulate the right team, the right time to deliver, and the right approach to manage. In summary, even at highly specialized referral center, placenta spectrum diagnosis is very difficult and imperfect. Clinicians should maintain a high index of suspicion and a low threshold for referral for a specialty center with placenta acute spectrum experience. Point 2, system preparedness. System preparedness may be more important than any individual clinician experience or skill in ensuring safe and effective care for patients with known or suspected placenta acute spectrum. Unfortunately, up to 50% of patients still misdiagnosed. All facilities offering obstetric care should therefore prepare an action plan for unexpected cases and routinely engage and comprehensive self-assessment to determine whether routine placenta spectrum should be performed locally or better to refer. Assessment, point number 3, assessment and optimizing resources of placenta accreta spectrum. First step for hospital providing obstetric care is to determine whether they have the resources enough and the experience to manage planned placenta accreta spectrum. Planned is first, then emergency. At minimum, and based on recommendation by American College of Obstetrics and Gynecology and Society of Maternal Fetal Medicine, states that hospital planning to manage patients with suspected, not surely diagnosed, just suspected accreta or even placenta previa plus prior-uterine surgery should have available resources of maternal level 3 or higher. Specifically, hospital should have in mid-24-hour access to the following: blood bank service with the ability of massive transfusion, neonatal and adult ICU, obstetric surgical experience in managing complex maternal and obstetric complications, such in our talk, placenta accreta spectrum. The effective interdisciplinary team of such a problem is characterized by the following: by a leader, membership from maternal fetal medicine, obstetric gynecologic surgery, anesthesia, critical care, intervention radiology, neonatology. We added also neurosurgery. Ability to quickly mobilize an experienced surgical team at all times, 24-hour, 7 days per week. Interdisciplinary team planning meeting or formalized communication as a regular or follow-up protocols. Standardized evidence-based approaches to placenta spectrum diagnosis, staging, and management. Number 4, coordinated perinatal management. It have multiple points to discuss. I will start by antenatal care. Start to comprehensive antenatal care for patients with suspected such syndrome. You have to start the beginnings by detailed risk stratification, maybe so early in pregnancy, for tailored counseling and the goals of care discussion. Then identify any risk factor, either obstetric history of routine or routine image, which may be in need for dedicating placenta accreta spectrum severity assessment, and by the way, both the sweat or fit protocol for management. Then personalized counseling for patient accept accreta spectrum needs to be both practical and emotionally supportive. Take into account the disease severity and the possible morbidity, which could happen intraoperative or post-operative, remote from the delivery. Give proactively mitigating hemorrhage risk assessment, arrange the timing and location of delivery, and coordinating the multidisciplinary team. The predominant risk factor, of course, of our talk today regarding placenta spectrum is obstetric hemorrhage. Making timely assessment of hematologic parameters and the iron store is one of top priority. Optimizing hemoglobin before delivery may be required for high concentration iron replacement with intravenous iron formation may be in need based on the laboratory workup. Anticipation of blood loss and the plans for intraoperative management should be discussed and coordinate with anesthesia, which is effective and familiar with obstetric transfusion and the need for serious resuscitation. Of course, early consultation of anesthesia, and by the way, neonatal expectation to be informed of NICU staff, especially if you will deliver patient premature. In addition to planning intended delivery scenarios, the team needs to establish contingency plan for how and where the pregnant patient can seek appropriate care in case of complications such as hemorrhage or contractions. You have to consider inpatient admission if needed. Throughout the pregnancy, effective and frequent communication between the pregnant patient and the medical team should be one of top priority. Delivery time, based on recommendation of American College of Gynecology and the Society of Maternal Fetal Medicine, patients have to deliver if stable at 34 0 days up to 35 6 days. I said if stable, I mean no bleeding or labor signs. Preoperative preparation. There are several additional aspects of immediate preoperative preparation, including checklist and appropriate consultation. Blood type, antibody screening, consultation with the bank should be done days before the day of surgery. On the day of surgery, prepare your team for the possibility of significant systemic effort and the massive transfusion may be in need. At minimum, adequate intravenous access for fluid and the blood resuscitation, multiple large volume intravenous catheter, invasive arterial monitoring should be ready. Coordination with anesthesia for managing massive obstetric hemorrhage, large volume replacement or transfusion, invasive hemodynamic monitoring is crucially important in each case. Pre-op reflective catheterization, which I consider it the main core of our project. Ureter may be at risk during cesarean section in general. Of course, it will be more and more risky in cases complicated by placenta accreta syndrome. In cases that may involve the ureter, catheterization may add their dissection or identification. In our practice, we advocate preoperative urethral catheter placement in every case. Aside from hysterectomy, ureter also at risk during repair, hysterotomy extension into brood ligament or vagina, which is commonly happened. However, this catheter overall don't lower urinary tract injury rate. I put question mark. Yes, I know it does not. It didn't reduce the rate of injury, but of course it increased the rate of identification of such injuries intraoperative. And by the way, it's much better to identify them post-operatively. So American College of Gynecology 2018 said that some, but not all, advocate preoperative urethral catheterization as a routine. Based on recent articles published in American Journal of Gynecology and Maternal Fetal Medicine regarding prophylactic urethral stent placement for urinary tract injury during hysterectomy for placenta spectrum, it was systematic review and meta-analysis. It still says that no difference in the rate of genitourinary injury with the use of such stents. Delivery and the treatment. Optimal surgical approach will depend on individual disease characterization, gestational age at time of delivery, surgical team experience, and institutional resources. So we have 4 strategies for the management of placenta accreta spectrum. Briefly, cesarean hysterectomy after delivery of newborn with still placenta in situ, conservative in situ management of placenta, planned delayed hysterectomy weeks after in situ management, and the partial myometrium resection with uterine reconstruction. Cesarean hysterectomy as the start, it is the most common approach practiced, and it's the default backup plan if other strategies fail to control the problem. In absence of severe disease and with experienced surgical team, this approach reduces the risk of worst outcome highly in compared with alternative approaches. Patients with placenta spectrum are risky to develop severe bleeding with minute laceration. It will be related to the underlying pathology, pathophysiology, the development of the baby in the form of increased blood rate, a change in the construction of the uterus. It becomes less collagen and more watery, edematous organ, and by the way, increase in size. The uterine tissue is soft edematous vascular, so requiring dramatic adaptation of tissue handling compared with non-pregnant hysterectomy. Operating also in retroperitoneal near the pelvic side and distorted lower uterine segment by placenta, often with so close that location to the uterine arteries and ureter, plus distorted bladder, plus high index of abdominopelvic adhesive disease due to previous operation. We in our project put our recommendation as at next in the technique. Always we do vertical midline incision to adequate exposure of the uterus and pelvic dissection, hysterotomy away totally from the placental side to avoid any laceration or bleeding, using serial clamping to vascularize an area for entry of hysterotomy, do stepwise devascularization of uterus beginning as a uteroovarian pedicle, allow progressive mobility and reserve the most difficult dissection for the last to allow fast specimen amputation if bleeding is increasing. Electrodissection alone or in combination with sealing devices and the traditional social ligation technique is typically used. Here. Second strategy, conservative in situ management. It is after delivery of the baby, away from the placenta, the cord is strained and tied so near to the insertion, then the uterine incision closed. We do evaluation. If no immediate bleeding complicating the field, the abdomen is closed and the expected management continue as long as no evidence of significant bleeding or infection. We have advantage of reduction up to 70% of transfusion, blood loss, operative injury to urinary tract or colon and also avoiding hysterectomy in most cases 78 up to 97%. But also we have this advantage, which include emergent reoperation, the need for prolonged and complex follow-up, endometritis 11%, and the presence of hospital and the chance for hospital readmission was much higher compared with immediate hysterectomy. It was 29% versus 3.4%. Planned delayed hysterectomy, interval hysterectomy after delivery may reduce the risk of associated by both immediate hysterectomy or conservative management. Before the delivery of the newborn by cesarean section, a systematic evaluation of the uterus, bladder, parametry, adhesive disease, and other pelvic structure are essential. After delivery, both another systematic evaluation for the abdomen and pelvis is performed to ensure integrity of the hysterotomy and the absence of significant bleeding, which would be contraindicate the delayed management. This advantage, of course, frequent readmission, follow-up for prolonged time, bleeding, and sometimes development of infection. Finally, partial metal resection and uterine reconstruction in highly selected cases in block resection of limited placenta and attached myometrium without any trial for separation, then followed by repair and reconstruction of the remaining uterus and the cervix in one setting. Important to successful is to decide whether to attempt resection or proceed for hysterectomy, which is based on how sufficient viable myometrium tissue surrounding the affected area, degree of hypervascularity, location and severity of pelvic disease, adhesive disease. Pelvic devascularization by compression suturing incorporation of the cervix into the closure tourniquet placement can reduce the blood loss during such reconstruction. There are major unresolved questions about future pregnancy regarding recurrence of the syndrome, rupture uterus, and the preterm birth. Another scenario, what we call another dilemma, it's a unique situation, spot diagnosis, what we call on-table diagnosis of intrapartum placenta acute spectrum. It needs a complex clinical decision making highly indicated for evaluation for bulging abnormality, vasculature of lower trans segment, or extrusion of placenta. In case of fetal of maternal instability, we have no chance to do anything except for rapid delivery, then reassess again. But in stable patient, you have to decide whether proceeding with delivery or transporting before delivery is based on available resources and experience. The period after delivery, either vaginally or by cesarean, is another critical time if placenta active spectrum is the diagnosis. At certain situation, close uterus and the abdomen with the placenta in situ and may be safer than attempting hysterectomy in low resource setting and refer for highly specialized center. Another point very important to be considered at certain situation is endovasculature approaches to reduce the blood loss. As I said before, blood hemorrhage, excessive bleeding or hemorrhage as a time of intraoperative and even post-delivery of the baby cannot be anticipated and cannot be predicted or prevented in some situations. So anticipating the potential for large intraoperative blood loss, some centers calibrate the intervention radiology to both endovascular approaches to reduce blood loss, including balloon occlusion or embolization. To give dry field during surgical maneuver. The first is blood occlusion. Blood occlusion can be applied at multiple vessels from distal to proximal, including placement of uterine arteries, internal iliac, common iliac, or even distal abdominal aorta. Meta-analysis found that it results in significant less of bleeding compared with no intervention. Serious complications include balloon migration, balloon rupture, vessel intimal injury, pseudoaneurysm, arterial thrombosis, limb ischemia necrosis, multi-organ dysfunction plus exposure for radiation. Regarding prophylactic multivessel embolization, in a trial to overcome such a complication, it has similar efficacy regarding reducing, but still need further and further assessment by prospective studies. Postpartum area, including short and long term. In short, after initial treatment of patient requires attention to specialized needs, often include critical care in addition to routine postpartum. I mean, they need extra care as clear communication between obstetric team and the critical teams, including obstetric and intensive experience. in achieving attainable element of the normal postpartum experience. Patients with such syndrome unique needs beyond postpartum, such as pain level, urinary function, folic acid removal, epidural discontinuation, expectation for bleeding, understanding intraoperative event, and the return of appetite. All of these are just some example of care elements. Long term, it is totally misguided to consider the work and the care of provision of placenta accreta spectrum to be complete once the birthing parent and their new need are safely discharged from the hospital. Regardless that, patient and the families affected by such syndrome find it helpful by provision of education material and standardized planning and recovery protocol to overcome what we call emotional distress, fear, feeling of loss, and the varying degree of trauma. Collectively, what has been called living beyond placenta accreta spectrum. Now, give an idea about our project at King Faisal Medical Complex in Taif. Placenta accreta spectrum disorder is a potentially life-threatening condition with multiple morbidities. So our leadership decided to launch a project for reducing such morbidity associated with the syndrome. The project implemented as retrospective study. Our objective to build a pathway by integrated team professional who can work in collaboration and coordination to reduce such morbidities associated with such syndrome. The project addressed that which all second global patient safety goal, including safety section and the patient safety training and strengthening capacity of healthcare provider. We ensure the ability of written up-to-date clinical guidelines and protocols and their utilization in case of placenta accreta spectrum. Our aim to find out whether integration of such a pathway using interdisciplinary approach could bring improvement in our key performance indicator, KPI, related to maternal morbidity in such placenta accreta cases. A change of surgical protocol along with interdisciplinary planning was administered for management of such cases. The contributing member of our team, including obstetrics and gynecology, urology, interventional radiology, NICU, and anesthesia department, each one have to do his experience in the field. Our plan, performance improvement plan, we unified our planning process and implemented this policy in our department. The intent is to evolve the concept in an inclusive manner within our institution. We modify the interdisciplinary team updated policy has clear modification in some points, including the need for pre-operative ureteric catheter or ureteric stent for all cases before going in surgical in planned operation, planned placenta accreta spectrum patient. Orientation and awareness of such was done. Establish anesthesia clinic in our maternity OPD, thereby providing adequate pre-op evaluation for high-risk pregnancies. Establish a unified means of communication across maternity tower and the main King Faisal building for effective communication, including the members of our team for working. Such a pathway was established in an interdisciplinary team, including the department mentioned before. The scope or the purpose of this pathway was to improve the patient safety and achieve better maternal outcome in terms of reduced need for ICU, less hospital stay, reduced blood loss, and by the way, massive blood transfusion, and the prevention of lower urinary tract injury during cesarean section. The time frame of implementation started at Jan 2022 and ended by June 2022. It was our placenta spectrum pathway. Total of 33 women included in the study. To specify the ends of our result, lower urinary tract injury were reduced from 26% to our maternal ICU admission reduced from 52% down to 15%. And this requiring massive blood transfusion declined from 47% down to 24% after implementation of the placenta spectrum pathway. The length of stay reduced from 8 to 10 days to 3 to 4 days. Hence, the project is cost effective by about 9 million Saudi Riyal over 6 months only. All women with such a pathway receive maximum care, which is offered by a multidisciplinary team with specific time frame with 80% reduction in the maternal morbidity. The provision of increased number of multidisciplinary team component was associated with significant reduction of such morbidity related to placenta accreta spectrum syndrome. It is our table showing our statistics. Our data is important for several reasons. They have been gathered retrospectively by a consistent team in a single tertiary care center. Second, we used predefined criteria of severe maternal morbidity. Our assessment were able to demonstrate a significant reduction in the risk of several maternal morbidity items through stepwise application of a specialist component of care. Third, our approach has been inclusive of all obstetric staff and in order to broaden institutional experience. The project result is therefore useful when counseling women with suspected placenta accreta brevia or increta during antenatal periods. While it's large successful, our approach differs significantly from others. First, we use preoperative uterine stent through cystoscope in stent discovery intraoperative, which is very, very important regarding patient safety and avoid reopening again. Second, we had a high rate of use regional anesthesia instead of general anesthesia. This major difference illustrates the need to create links between regionalization between groups to define best practice. When planned further, more detailed examination of our experience in specific aspects of the care of such women. To be honest, our results have limitation by relatively small sample size. Sustainability plan. After the project, over a period of 1 year and of 9 months, we have the program of diagnosis and management of invasive placenta brevia at a busy high-risk obstetric institution at King Faisal. There was 80% reduction of overall maternal morbidity. Our experience is that collaboration between such clusters of people functioning on regional basis can form foundation for the development of new methods and the clinical tools to improve the clinical outcome in this increasing common condition. This include development of organization flow charts or sheet, standardized protocol that streamline effective care and to conduct prospective research and creating a strong post-graduate learning environment. Network between such a cluster of centers across Kingdom is like to promote effective guideline development that will demonstrate population-based improvement in prognosis in this condition. The reduction of morbidity is sustained, is seen in monthly, hence the pathway adopted could be used in other tertiary care centers for improvement. Thank you very, very much.
Thank you very much, Dr. Mustafa, for addressing this very, very interesting topic. And it is the need of the time. Dear participants, kindly, if you have any questions, you're most welcome. Now the house is open for question and answers.
Yes, Dr. Adila, I'm ready.
Okay, yes, Dr. Mustafa, I'm with you. So the first question is, can you discuss the role of MRI versus ultrasound in the assessment of placenta accreta spectrum?
Yes, the guidance rule for MRI I said before in my slides, it is of limited rule regarding the diagnosis, only to be used when our risk factor and the ultrasound cannot attach the final diagnosis, and we are inquiry about how to do. The MRI is very expensive, not available in every center. It needs experience in interpretation of placental MRI. So the golden rule for diagnosis is to achieve by clinical assessment and the certification plus ultrasound study. If you add double ultrasound, the accuracy and safety of the test will be more and more. So you will remain just a few cases indicating for diagnosis of by MRI. Like to say that MRI is a routine for investigation, at least in my opinion and in our organization, it's not as a routine.
Okay, thank you. The next question is, when is the planned cesarean hysterectomy indicated? Planned cesarean hysterectomy, when is indicated in cases of placenta accreta?
Yes, Dr. Adila, I said before, the plan for the protocol of management have to start early in pregnancy, early in antenatal, based on individualize the case, the patient, as I said, comprehensive assessment of risk stratification, and then do personalized counseling for the patient regarding how aged is she, what about the children she have, what about ultrasound and other risk. For example, if you found a patient is just 30 years old, gravida 3/1 plus have gravida 3/2 plus O, one previous section, and has placenta spectrum. Ultrasound denotes that the placenta is just to be accreta. You have to count the patient. We'll do our best to avoid the chance of hysterectomy as we can, except to be life-saving. It will be totally different for a patient is 40 or 40, has complete his family size and have previous 4, 5 CS, and also denoting the invasion of the bladder. It be planned before that the usual protocol we go for hysterectomy with a start, because any trial to separate such adhesive and the dramatic bleeding condition will be maybe life-saving. The final decision will be taken intraoperative by intraoperative assessment before any touch. As I said before touching, you have to re-evaluate the size of placental bed attaching to the bladder, just involving the myometric node attaches the serosa. You can go for resection of such area with the myometric and do reconstruction. If in some centers, but not in our department, in some centers, still we have to may go for keeps the placenta in situ as expected management for resorption or if complication happens. Yeah, I mean, you have to decide by antenatal assessment, the critical risk factor and the ultrasound, and if need MRI, but final decision after patient counsel, of course, will be intraoperative.
Okay. There is one very interesting question from one of the audience. They asked when we can diagnose placenta accreta spectrum, at what gestation we can exactly say that diagnosis is confirmed.
It's very nice question. It's a very nice question. I said in my slide, the role of ultrasound started so early in pregnancy. I just said at any patient have high risk. What high risk? Previous section before at least once. He has to do ultrasound between 6 and 10 weeks of gestation to diagnose what we call cesarean scar pregnancy, which you consider now as the cursor of development of placenta spectrum later on. If you find, you have to confirm the diagnosis and manage this problem. Manage the problem at early gestation. There is multiple options of treatment. You could preserve the fertility in such a case. However, if you find this one is not okay, you have to go second trimester ultrasound. Any patient with previous uterine surgery, mainly lower uterine segment, have to define clearly what is the location of the placenta in relation to the upper limit of service, what we call scarred area. If the placenta is located as such scarred area, detailed ultrasound examination to denote if there is signs. I said before 9 signs for placenta spectrum. All the placenta is totally away from such area, the possibility of such condition is very, very low.
Okay. There is a question about anesthesia. What type of anesthesia are you using in your center? And is
our center, alhamdulillah, still using regional anesthesia, I mean spinal anesthesia, which is very effective in such a condition with high level, even in cases with minor incision as usual in our protocol. Spinal anesthesia is enough in most cases, but not all cases. Yani still general anesthesia could be as a backbone for failed spinal anesthesia. Like you can stay, yeah, the usual route worldwide is general. Like there is some center including us, spinal anesthesia is the primary.
Okay. So, Dr. Mustafa, there are some ethical and psychological dilemmas for the patients who have this placenta accreta spectrum ended up in being hysterectomized. So, how do you handle these ethical dilemmas?
Yes, it is very important to start before going for delivery. And once you did, you said again and again, you go for protocol for diagnosis, including stratification or risk factor and the ultrasound. Keep in mind that this patient got pregnant normally, and she considers his pregnancy is totally normal, and she should go for delivery as anyone normal and go back with a baby. It is her psychology now. All of a sudden, a second or early third trimester, you mentioned for her that the patient have placenta active spectrum, which is very, very risky, and it may be ended by hysterectomy or loss of fertility as usual, and in some situation maybe in bleeding happen, go for premature delivery. Yani be loss of fertility and the loss of the baby as well. In such cases, it is not enough to go for short-term postpartum care. Long-partum care for the patient and his family about feeding, about loss of fertility, about what's ongoing needs greatly support by intensive medicine and by obstetric team, and also by psychology or psychiatric therapist to deal with them very emotionally, even group therapy, citation on that how to deal with such a problem is very important to achieve good psychological support for him. Yani not to start after the problem. You have to prepare the patient for what are ongoing. That's why I said before why I know that the primary hysterectomy as a golden rule for management of such cases. It's the primary option for yani most of our clinicians. Yes, it's the safest one if needed, but if you can preserve the uterus, at least it will be give great positive energy for the patient psychology.
Okay. Can you kindly share with us some of your personal experience in managing some challenging case of placenta accreta spectrum?
We have in our center, King Faisal Medical Complex, many doctor professionals, including Dr. Gamal Qasim. He was well attended here. He has great experience in the management of such syndrome and even published many papers worldwide regarding how to manage this one. Alhamdulillah, we have I think we have more than 2 or 3 monthly with placenta active spectrum. Most of them delivered, and yes, I know that most of the needed for hysterectomy. But alhamdulillah, regarding hospital stay, bladder injury, ureteric injury, past this mostly, alhamdulillah, and most of them go for almost to normal postpartum periods.
Okay. Dr. Jamal, you are with us. Would you like to share with us some of your experiences as you have a distinguished name in managing placenta accreta spectrum in our hospital? Dr. Jamal?
Dr. Gamal? I will call him. Here is.
Okay, I think he's not here.
Wait, Dr. Wait.
Yes.
Another question, please.
Okay. There is a question. How do you manage massive hemorrhage during...
Wait, please.
Yeah.
Dr. Gamal, join now, please. If there is a question for you, join now, please. There is a question for you. Join now, please. Join again with the meeting. There is a question for you. ادخل اتكلم مع دكتورة عديلة فورا. You are out, Dr. Gamal. Rejoin again, please. Yes, Dr. Adila, what's the question again?
Okay, the question is that if you diagnose placenta accreta intraoperatively, then what will be your management strategy?
Yes, I said in this 2 slides, it's a big dilemma, need complex decision making. If you found your patient in bleeding or baby in distress by CTG orientation, you have no hope. You have to go for cesarean, deliver the baby, and after that reassess the condition. But if you found as elective cesarean section sign or manifestation of placenta spectrum, once you open the parietal proton, is a form of bulging, great vascularity in lower uterine segment, some sort of protrusion or extrusion of placenta, you can see dampening sign. You can see placental tissue through very thin myometrium of even 1 layer of serosa. In such a case, you have to take decision. What is the in such a stable patient? If you have the experience needed and your environment, I mean theater, operative theater, have the needed resources to manage such a placenta acute spectrum, you have to go and manage accordingly. But if you cannot, I mean lack of experience, of your resource is limited, not enough to manage such condition, you can close the abdomen again and refer the patient for highly specialized center. Another point of importance, if you go for delivery of the baby and still, of course, delivery of the baby in such a case, totally away from the placenta to ensure the minimum amount of bleeding can occur. After that, reassess again. If you found lack of experience, lack of resources at your department of environment, you can close the uterus with placenta in situ and the abdomen and refer for further management of such condition at a tertiary or prepared center for managing such conditions.
Okay. Thank you so much, Dr. Mustafa, for your comprehensive and detailed presentation.
Well, you are welcome.
Yes, we were waiting for Dr. Jamal if he could join. I would love to hear his experience, but I think he's unable to join. No worries. On behalf of Saudi Patient Safety Center, we would like to thank Dr. Mustafa and the audience for their active participation. As a part of
Radia, Dr. Jabal, can't come back.
Yeah, Dr. Mustafa, Dr. Jamal, I can hear you. Are you in? Dr. Jamal? Yeah, because you have a lot of experience in our Center for Managing Placenta Acute Spectrum, one of the leaders. So I would love to hear your experience in this field and have a word with us, please.
You hear me, Dr. Adila?
Yes.
Welcome.
Welcome, Dr.
You hear me?
Yeah,
yes,
Dr. Jamal.
Welcome back.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. I am very proud of my center, very proud of Dr. Mustafa and Dr. Adila and all my colleagues working in the department. I think our center is a great center. And now we have a very good experience and very too much reduced morbidity and I would like to say we have no mortality in our center since I joined the department. We have no mortality, although it's internationally written. It is mortality from placenta accreta or placenta accreta spectrum may reach 7%. We have. You hearing me, Dr. Adila?
Yes, Gamal, yes. It's okay.
So our center is a great center. Our center is a greatly professional center. We regarding the technique and the preparation, Dr. Mustafa have discussed too much about the subject. First, most important point, you should start with midline incision completely away from the placenta, and you are even extend upwards. So you can dissect from upward. You can start dissection, separating the peritoneum from the anterior abdominal wall and separating from the uterus from the highest portion. You may imagine that in some cases of previous resection, the bladder is so much high. Second point, you can fill the urine bladder with 50 to 100 ml, so it will appear during dissection. So it will go down. One of the most important item in management of placenta accreta is the avoidance of traction. Don't remove the placenta forcibly. If you feel that the placenta is adherent, you can close the uterine incision rapidly, keep the placenta inside and the umbilical cord inside, and you can start hysterectomy or focal or local or focal resection of the most bulging area. But in cases of Burkittite, you will proceed directly. One of important point, if you have difficulty in dissection of the urinary bladder or from the uterus, start from due to previous addition, for example, start from the easiest one. Start from the easiest one, but don't go lateral too much. Don't go to the lateral pelvic wall. Start from the easiest one, highest part. Placenta will dissect with you one by one. Then one of difficult point that when you are going down, you hear me, Dr. Adila? Dr. Adila?
Yes, Dr. Jamal.
Jamal,
yes.
sorry,
One
my
of
mic
important
was
point,
on the mute.
whatever you are doing, what you are going to do, total or subtotal hysterectomy, you remove the uterus just below the placenta, But the problem is that the lower segment is ballooning with the placenta. So initially, we are afraid we cannot we cannot clamp or catch the uterine artery. You can gently elevate the uterus and squeeze and put your clamp on the uterine arteries on both sides. Then you can cut. This is a very important point that we gain experience at. In cases of Burkittite, for example, while you are dissecting, the placenta will bulge from the lower segment, making sometimes horrible bleeding. Don't be afraid. Don't worry. You will just compress it. When you are dissect. So you will put uterine clamp on the uterine artery. Bleeding will decrease. If you did the supravaginal hysterectomy, still bleeding of the stump, you should remove the whole stump and making total hysterectomy, because there is some connection between the lower segment. If you leave part of the cervix and the patient still has bleeding, you should remove it. Then ureteric catheterization. I think ureteric catheterization, although it is written in the literature, it is not routinely recommended. But we have here in the Western countries, they have little cases previous for high order cesarean section. They have little cases. We have here very difficult cases of adhesions. So I recommend in individualized management of preoperative ureteric catheterization, but better to be done, because we have here more cases with previous 3 or 4 or high order cesarean section. There are many points, but I wanted to confirm what it was very nice, very clear demonstration of Dr. Mustafa.
For us, it's routine, Dr. Jamia, صح?
Huh?
Our department, for us, it is routine.
It is routine. We have too much improvement, but yes. I want to recommend something, Dr. Mustafa. We should train more person. Not only few some consultant can do. We should share more, Dr. Mustafa. I think we should share in the next program. Dr. Mustafa, last point. Yes. We should improve, because experience is very important. I got experience, and which is reflected in a much improvement of the patient morbidity and mortality. Thank you very much. Your lecture.
Thank you, Dr. Jamal.
Very clear, very to the point, very clear.
Thank you so much, Dr. Jamal, for your kind words and for sharing with us your experience. So now, Dr. Mustafa, would you like to say some take-home message in just few words?
First of all, thank you so much for Adila and for all the attended. Thank you for Ustaz Heba and فريق العمل الكامل. Really, it's very important to share experience like that for Dr. Jamal Qasim with our centers. I hope if anyone have experience to share us with it for more and more improvement and more.
Okay. So on the behalf of Saudi Patient Safety Center, I would like to thank my distinguished speakers and our guest speaker, Dr. Jamal, and all of my audience. And thank you as a part of the Patient Safety Center's efforts to provide us with the timely topics and interesting speakers. We would appreciate it if you would fill out the evaluation survey provided at the end of this webinar. And thank you for joining us today. We would look forward to welcoming you back in the future.